Jeff, I've been excited about this because, obviously when I first met you, you were really probably the first like DPC doc that I really interacted with, not just to basically understand what the model is for an employer or a member, but rather you were kind of sitting with me on a beach of all places, right? Where we were both presenters, but you were practicing on the beach. You were helping patients right there. And I remember as you were kind of discussing the experience and the interaction, it allowed me to then kind of ask questions as I was watching this experience, and I was able to correlate that as to say, why is this so different than how we typically access healthcare? And I think you just touched on something. It's that there's this idea that in DPC we're actually promoting the relationship with the physician. However, the way we go about it is very different than like an employer setting where the employee shows up at an open enrollment meeting and says, here's your benefit and here's how you're going to access healthcare or that benefit. But there's nothing in there about the provider whatsoever. It's just kind of a free for all. Whereas with you, a member is selecting to have that relationship. And so we've kind of looked at it, and I've looked at it and said, well, why can't an employer go halfway? Why can't an employer say, you know what? Not only do I believe you should actually go have a relationship with your primary care physician, I'm going to remove the financial barriers to prove it to you. Because I think that's part of it, is that the messaging up to this point in plan design has been don't go, right? Because, well, just wait until you finally have the huge service. Well, then you're going to have to pay your full out of pocket and deductible. Then you can have a great blowout year of healthcare and use it all up and then be fearful again. And DPC doesn't result in that. So if all of a sudden you remove those financial barriers, the message back to the plan member is, I do want you to have a relationship with your primary care physician. And I've actually seen this happen across employers that really deploy this this philosophy, to where we've even had providers come into those open enrollment meetings. And instead of us saying, hey, here's the benefit, it's rather, hey, here are the providers, here are the services that they have. And oh, by the way, here are some things that they're seeing going on a lot right now within the community. If maybe one of these things applies to you, they're going to be sharing some information today on maybe how you can address it. So now in that meeting, you're not in a healthcare setting, you're still in the employer environment, but you've now invited healthcare into it with this real idea of access at the primary care level, frontline providers, whether that is the MD, the PA, whatever that might be, just go access healthcare and begin to have a relationship. And I think to your point, that's where the two start to converge. And now the benefit is that the provider's allowed to practice and take care and help the person get well. And I think now we've got true engagement of healthcare going on. So the messaging has so much to do with it.
And not just get well, but you're really building a process or an ecosystem where you can actually magnify health.
Absolutely.
That's where those savings are. Be healthy.
I mean, I think, if I look at, which is what I'm trying to do, is redesign a whole new healthcare system from the bottom up rather than the top down. And if I had, and I think unfortunately it would probably put, both of you guys out of a job, but if I really had my way, I mean, employers would have nothing to do, with health insurance and health benefits. It would all be an open market where, people can keep that money in their paycheck and shop for the insurance that they need. But we know that that's not changing anytime soon. So like what I proposed to Mark, and this is like kind of touching on what Doug just said, is why is there any benefits firm or consulting, brokerage, or even an employer that doesn't have a chief medical officer on staff? You guys are arranging benefits, which is your area of expertise, it's your lane, the pricing, all that kind of crap. But why does not every organization have a physician on staff that can say, let's look at this, population of employees, and how do we, come up with a strategy that we're vetting, who the doctors are that they're going to. Is the community hospital a lot better than the big tertiary hospital for certain things? 100%. Why are we not almost like an advisor? Just like
Hmm.
every company has an accountant, they have, someone who helps with their 401k and set up the
Yep.
plan. Why is there no physician
I
involved in that?
I have a very good answer for you, and it's because I tend to look at the industry and ask questions of why do we do things the way we do? Meaning, how does this mechanism work, and why is it we behave in certain ways? So the first thing is, if you think about the advisor's role, what are we really for? And right up until this point, yes, we're seeing people break out and start to really understand and know that you've got to almost build a plan from the ground up if you're really going to be successful. But that has not been the way that this has been done up until just the last several years. It's always been a product-based world. Now, what are they selling? Insurance. At the end of the day, we're selling insurance and networks. There is no real, it's then just a matter of, well, who has the most providers? There's no discussion of what are the best providers, what are the best provider relationships, are there any, coordinated care networks, nothing like that. We're really having very little of that discussion. We don't understand it because, well, we know is on the spreadsheet, the price doesn't dictate that one of them is going to be less expensive. So I think that's the first part of it. But then think about it on the other side is that even with the health systems themselves that maybe would have a desire themselves to engage more directly with an employer, they're in essence shielded by that by the insurance system as well. So but via the networks and things of that nature. And as I've spoken with large health systems and we ask these questions about the employers and what do they know, literally it's just this black, it's a blank stare. They have no clue what the employers think or know. And to your point, what do you think that the health system CEO would say to that employer with 10,000 lives? What do you mean you're just running this off of a financial game on your spreadsheet? 10,000 lives, if you actually had a doctor looking at this, you guys could probably save 10 to 15% and actually improve your overall population because you would start to think a totally different way. And so that's been my recognition is that the insurance world by design has created these fences between us. And they then get to keep all of us in our lanes to where we don't understand how we're actually, pardon my French, screwing one another over. And so that's where I've learned when you remove the insurance component of it, not only can you start to get to collaboration and starting to take on a more proactive and wellness, right, healthcare type approach and strategy, but now you can even start to look and dream and say, like, does DPC, would that type of a model where our employees would now be engaged in the decision process, is that something that one would be attractive to our workforce? And we all know the answer to that is, heck, yes, it is. Sign me up yesterday. And so then the problem is, well, how do we build that? Well, now that you remove the networks and the insurance, it's really not that difficult. We sit down with the provider and we say, we'd like to pay you. We'd just like to pay you monthly as opposed to on a fee for service basis. And I will tell you, whether it's yourself as an independent provider or even the largest health systems, there is a desire to better understand how we do create that almost guaranteed revenue, but with value in return type buying experience. And so that may still include some employer, but I also believe it is a way to where we can get the member back engaged as well. I think the employer does have a role to play, but it is from that risk management standpoint. So to your point, Jeff, the advisors in the world, I think as we continue to evolve and stop looking at insurance as the solution and rather realize healthcare was the solution all along, you probably are going to see employers that put a much stronger investment into building strategies around that. And it will certainly involve the clinical community.
But does it
Yeah, I mean, I think that's, go ahead.
Go ahead.
Well, I was going to say, I mean, the thing I, sent over to you, Kim, to read, and Doug, I think, read it a while ago is, when I wrote that piece, like framing it in the addiction model, because I think that it really is an addiction to insurance. Like it's, and if you've ever read, I think we talked about it the last time, but if you've ever read the book Dreamland, about the opiate epidemic and how it came from the cartels in Mexico into the States. It's like, we're going to give you this product for free, right? And we're going to get you hooked.
Mhm.
And once you're hooked with your $10 copays and everything, everything covered, over the years, we've now got you dependent on this thing that now we're giving you concrete examples of where it's bad for you, and yet you can't pull away from using it.
Well,
I
that's
mean,
because, but that's because don't you think insurance has a certain amount of safety to it?
of
That's
course
why we
it.
have insurance, right? So then you come up, and the question comes to my mind, does it have to be mutually exclusive? I mean, I mean, I think for most, for many people, we need that level of wellness care, but there are those outlier situations. So what do you do in those cases where you have this horrific accident, or like a Lou Gehrig's, or like a
Right.
dialysis or a cancer, those things. I mean, there's a place for insurance for sure.
Of course, 100%. And I always say, one of my quotes is, I have nothing against insurance. I'm just tired of using it as a payment model for dumb shit. If we use it the way that it's intended to be used, just like we do in every other industry of insurance, not only do we drive the cost of so much care down
Right.
through transparency and competition, but we actually start driving the cost of insurance down.
Absolutely.
Yep.
Put a leash on it. Like to Doug's example when we were talking about last time, insurance, you don't have your auto insurance to pay for your oil changes, or your tires, or those they're not best served by insurance.
Right. And that's where, though, I'll, in that article, I mean, I had a literal dialogue with a patient. Um, how much of these labs with insurance, I don't know, but you're on a $2,000 deductible. So I can guarantee if we run them through the hospital, they're going to be more than, the $20 cash price that we're offering you. And, well, I pay a lot for my insurance, so let's use my insurance. And I said, do you realize the reason you pay a lot for your insurance is because you keep using it? Well, yeah, but still bill my insurance.
That's just
Like, this
because
is
they
what this
don't understand it, though. When people really
right.
understand, people always make good choices when they have enough adequate information. And the consumer, which we talked about last time, the consumer drives every industry. They don't drive in healthcare because they can't read the book.
Right.
There is
Well,
no book.
that's what I think. You know, one of the things I really want to do is, do you remember that book series, the yellow books, like Mac for Dummies or blah blah blah? You know,
Oh, yes.
I literally think we should get like a cartoonist and literally write at like a third grade level in a cartoon format, like the 101 of using insurance.
I
Yeah.
said it. Doug can do the drawing.
No, I don't have time.
I don't either. And all I can draw is
Draw
stick
stick
figures.
figure. I'll be the drawer. I can't guarantee we'll
Yeah.
sell any copies though.
But, I think it's one of those things that I think I've been approaching it, especially in this area where I am, where it's so insurance driven and so insurance addicted, is I've been approaching it the wrong way of trying to sell, good quality primary care, when the reality is you got to start with the insurance first and explain to them, how do you make your choice of insurance? Are you buying the right, whether it's a company or a family, are you buying the right plan that suits your needs, or at least the closest to it? Like, obviously on the ACA, you're pretty freaking limited of, what you can and can't buy, because of the nonsense of the coverage requirements of preventive care and, all that BS. But, I think for the areas like that I'm in, maybe New York, the real high insurance driven areas, the key is really reteaching them how to buy insurance first. Should they be self-insured or on a level funded plan, or is it better for them to be on the fully insured market due to their risk? And I think the problem is there's not a lot of I think there's more and more people like Doug coming into the benefits world where, I think it's the same thing you mentioned about relationships. You have the brokers who are just like, okay, here's this. I got them from 18% increase to 16% increase. I'll see you on the golf course next year at renewal, but you have no access to your data. You have no idea what the hell's going on. And your employees may never even go to the doctor this year, but you're just out $500,000. I think there are more people that are coming in and saying, hey, look, maybe I don't make as much money up front off of you, but I want to develop a relationship with you and I want to guide you in the long game here. Because if we
Absolutely.
guide you in the long game, we're both going to reap a lot of rewards and you're going to have a lot more to show for it.
Yep.
And, but finding those people when they're out in Idaho, is pretty tough. I mean, I still like, I got a guy, we have a program in Massachusetts called the Commonwealth Care Alliance. And basically what it is, it's an organization that takes care of the duly eligible Medicare and Medicaid, the
Mhm.
sickest of the sick, most complicated, a lot of mental health, homeless patients, addiction, and I've gotten to know their CEO pretty well, and he came in. They were struggling, and he came in about 5 years ago, and literally has turned this thing around. And they're looking to expand in other states. And he's like, why can't we have a DPC program, baked into a
Mhm.
plan for people like this? Because he's like, these are the people that could probably need it and
Yeah.
use it the most. And he's like, even if it's a $250 or $300 a month per member point, you get a doctor who maybe they take care of 150 to 200 patients on their panel rather than 700, and you just watch the magic happen. But I said
Jessica,
to him,
I
who
wonder, is it because of the bureaucracy? Because I always see that the beauty is DPC is that it's a pretty simple transaction. As a individual, I'm engaging in a contract with you as a service provider. I'm going to pay you a monthly fee. You in return are going to provide services. But we've removed all of the paperwork and the pre-authorization and pre-certs, and you got to
Yep.
go here, not there, and all of that's gone. Right? It just allows you to
right,
just act freely. And I wonder if because it seems to me in a dual eligible situation, you're in two different government healthcare programs. Wouldn't you,
right.
as a provider, very likely, even though you might be getting that $250 to $300, you're going to have immediately significant sunk overhead costs by now just managing it from an administrative process. I would guess that would be the challenge in it.
Yeah, well, that's the problem that happened in, Washington State with,
Mm-hmm.
Q Lions trying to get a Medicaid pilot. And now I just read something the other day. I think Iowa, is talking about a Medicaid DPC pilot. And the issue is, like when we have meetings in DC with CMS about, a Medicare DPC pilot, the funny thing is it's all comes down to the data, data, data. And I just said, look at the bottom line is this. You guys already have all the data you need. You take 1,000 Medicare beneficiaries that are interested in doing a direct primary care model, and you plug them in the model, and then you do 1,000 that don't, and you just follow claims, like just follow specialty referrals, ER visits, hospitalizations. That's all you really should care about. But the issue that ends up being the nut is if they give the money, like no different than an EBT card, if they give the money to the patient and the patient becomes, like you said, that engaged consumer where they get to choose who their doctor is, they get to choose how they get their care, they lose control of the dollar.
Mm-hmm. Yep.
Right.
Or so they
So
think.
without them being in the middle, whether it's on the state level or the federal level, it's just never going to happen. I mean, look at what they even did with the proposed, bill that we had in there on the HSA issue. they literally wanted to put a cap on how much a DPC doc could charge per month in order for people to use their HSA. But yet I can go in for Mohs surgery, which I may not even need, and pay, $6,000 on an HSA account, and no one bats an eyelash.
Oh, no
But
limits
heaven forbid,
whatsoever.
but right, but heaven forbid you pay a primary care doc more than $150 a month. Not only can we not bill the difference, like if we charge 175, we can't bill the extra 25 to the patient. It also makes their HSA null and void. So, was it a step in the right direction? Sure. But the lesson I learned is they're never going to get out of the middle. And that's what I said to this guy is I said, look I'm happy to help you structure this in any way, shape, or form. And I'm sure there would be plenty of docs at community health centers that, would love to go into a model like this, but you're not going to see me doing it. I'd honestly, I'd rather take care of a Medicaid patient for free than have to deal with the coding and the billing and the ridiculousness that's involved in trying to get paid. And that's what happened with Q Alliance is basically the agreement was it's a flat monthly fee per member per month, whatever. And doesn't matter if the patient doesn't show up or not, like that's what it is. And then the government turned back and said, well, patient X hasn't been seen in over a year. Well, we're not going to pay you a monthly fee. Like, it's the doctor's fault that the patient didn't show up. So
Yep.
that's how they got burned. And I think that I just have no interest in playing that game. But the sad thing is I would love to see this model accessible to veterans, to Medicare beneficiaries, to Medicaid beneficiaries. But the reality is it's not going to be on our terms, and it's not going to be on the patient's
Agreed.
terms, and that's where it all just falls apart. And I think until we build the system up again from the bottom and show the power of what this can do, and it probably won't be in any of our lifetimes, but then you maybe get that one really big employer who donates, X amount of dollars to someone's campaign that says, look, this is what we're doing for our employees. We've put this in the community. You need to get behind this and not only get behind it, but do it the right way.
Mm-hmm.
Nothing will be different. Nothing. I mean, I argue, regarding getting back to like the EBT card, I say to people, look at if you take me as a primary care doc and you look at food, which is more of a determinant of someone's health, me or what they're eating? And I would argue that it's what they're eating. I
Yep.
mean, I can guide them, but the reality is what they do when they're not here in their day-to-day life is probably more important to
Absolutely.
their overall well-being than anything I do as a physician.
Mm.
But we can regulate less how many liters of orange juice and soda and Cheetos and snacks and cookies that they can go get, but we can't give them a card to say, hey, use this for your healthcare, whether you want to, whether you want a DPC doc, whether you want a community doc. Why do we have to be in the middle?
It's the most bizarre thing in healthcare where whether it's government, it's commercial, at the end of the day there's always some level of dictation, and it's almost never coming from the patient or the provider, the two people that are directly engaged. The whole process is almost dictated by a third party that
Right.
is not clinically trained, and they're not in the room. You know what I'm saying? So
Right.
it's like, why do we abdicate all this responsibility to other people? And maybe it goes back to fear, right? I think that's what it is. In most cases, when we engage in healthcare, it's fearful. So there's this inherent thought that we're not going to make good decisions. So obviously somebody's got to be providing oversight. And yet it's not on the patient who maybe isn't making the good decisions. The oversight is actually on the clinician, the one that's there trying to help. And it's quite perverse if you think about it, how none of it makes sense. None of it's in alignment based on what either of those two parties want. And I think it would highlight what's really wrong with healthcare is that the patient and the provider are not the ones in the seat to make the decision at this point.
Oh, it's
and
like
we've got to get there.
like a kid stuck in the middle of a nasty divorce.
Yeah.
Right. But it's
Yeah,
interesting.
you're right.
Like when you talk to folks up in Alaska, I know a few years ago, this concept has really been taken off up in Alaska. Right. So where are these, and they're little pockets of geography, geographically speaking.
Yep.
And I have a suspicion of why that's so, where this kind of model seems to be more attractive and take more root and have more support for than in other areas.
Mhm.
I don't know. And so I have some thoughts, but I'd be interested to hear from you guys. Why do you think that is? Why doesn't it feel more uniform in its desirability?
Well, I know the two reasons why I think there's resistance to the shift this direction. And then maybe Jeff can help us understand on then, how we get there and where, because I agree it does seem to be that there's kind of pockets. In my engagements with providers, it's not as often with kind of frontline primary care, but rather I'm dealing with executives often, even CMOs and things of that nature, but really those that are the leaders of the health systems, looking. Yeah, your CEO, CFO, COO, and strategy, and they really look at it as how are they impacting the community from a well-being standpoint, from a financial standpoint, the socioeconomic side of it. And I've actually asked them now, and you start get more brave as you have these relationships developing, and you learn more and more that really we give them a lot of credit for having way more vision and insight. And you'll find that most executives are just like us. They're going to point out a lot of the same exact issues. And a lot of us don't understand how to solve it. So when it comes to DPC specifically, and I've said, why hasn't, larger healthcare institutions, facilities, why haven't you all adopted this model? Because to me, it seems that when you get a patient engaged in a DPC type setting, you have total control at that point. And you guys are always looking for the steerage to make sure that then when you do need, facility-based services or, outpatient, whatever that might be, well, now you totally control the referral patterns. So not only can you tell them where they're going to go, but now you can even have better coordination of care, which, as hopefully Jeff would agree, should, in theory, result to a little bit lower costs and maybe some better outcomes over a period of time. And so why don't they do it? And the first part is, two things. One, there's a lack of understanding how to get there. And it's really tied to the second one. It's the revenue model tied to that. So healthcare is not as egregiously profitable as many would allow us to think. It really is kind of being funneled off more through the financial vehicles, the insurance companies. And so there's a fear that if they change too quickly how patients access care and how they're reimbursed, that can have a real significant impact on their revenue cycle. And so that's really where this fear comes from, is how do we get to the other side and know that we're going to have financial stability? But I have yet to find a health system. Yeah, none of them will come to you and say that we believe it's going to result in less financial stability. We're just not sure that we can absorb the ripple effect in between, the unknown. And so it's almost fear for them as well. And that's where I keep looking at it. And I feel like employers have a very strong role to play here, that if you can get the large health system and the employer at least engaged in a relationship, well, now you have two pretty powerful economic bodies that maybe control, several thousand lives. And I'm sure Jeff would say several thousand lives is a fantastic starting point. But then how do you scale that? How do you productize that to where it's no longer just for that employer, but rather that now establishes how we're going to operate the processes so that now this can become available to not only the larger employers in the marketplace, but then you can even be able to scale down while you're doing it with the health system. I believe that's the way to get there. But to the point, one, I don't know how to do it. And two, I also don't understand why the Denvers of the world, Even Cincinnati is shown to be successful. There are certain marketplaces where DPC just seems to be, rampant and successful and exciting, and people are appreciative of it. And yet you come to my town and where I'm at, and I'm literally going around to the physicians and saying, would you consider this? I will pay you X. I'm putting an offer on the table. They love the idea, but they're like, can I even do this? So that's how far we have to go to really get them engaged in it.
Wow. It's the wild, wild west.
Yeah, I mean, I think that it's one of those things where you have a lot of people that are extracting a lot of money through that payment mechanism that he mentions without adding any value whatsoever. Especially where, imagine if I could get, an underwriter to write a true wrap plan for Gold Direct Care that I could go and sell and have a product where all my bases are covered, but yet the big hospital systems can build their own insurance plan. So there's no conflict of interest there, right? You get your employees of your system on your plan, and obviously where is the steerage going to go when they're on your plan and they're employed by you, right? So the issue is you have a game where the refs and the coaches and the players are all kind of the same person, and you're trying to go up against them, and it's like how are you going to beat a team where the coach, the ref, and the and the players are all the same person, like a group of people? You can't, and that's what we're up against. And I think that the way you do that and really make a difference, and it's going to sound kind of corny and it's going to sound tacky, but it's literally, I think it needs to be a social movement. I wish people were rioting and protesting in the streets about this as much as they do other issues. Not that the other issues aren't important, but this is literally robbing people every single day. And, it's keeping poor people poor. It's keeping the middle class down from having their wages increased. And yet no one's riding in the streets about it. Nobody's talking about it in a way that is really effective, because the reality is, what do policymakers care about? They care about votes. And if you have a mass army of people that have a product that they really like and really value, no way in hell are you going to take it away from them, because if you do, you lose votes, plain and simple. And until we get that mass swell of, like Josh Umber from Atlas calls it the slow tsunami. It's like building and building and building and building until they can't stop you. Like, I mean, I'm at the point now I could be shut down tomorrow. If the State Department of Insurance, we have no legislation protecting DPC in Massachusetts, they could turn around tomorrow and say, well, without regulatory fees, you're done. You're in the business of insurance, right? We don't have that. The only way that we prevent something like that from happening is you get those smaller employers, then the medium sized employers, and then the larger employers, where most people, that's where they get their benefits through, is work. And you literally create a product that people have market forces that they just can't go without. I mean, no different than a cell phone, that they just literally can't be without it. And I think we have that product. I really do. It's a matter of how we get it to a momentum where, if you ever read Tipping Point, by Malcolm Gladwell, like, how do things, the examples, if you've never read it, the book is fascinating. Like, he talks about how things tip. And it's like, think back to when, we were in high school, and the white Keds, remember the white Ked sneakers that all the girls wore? Literally plain white sneakers that literally probably cost $3 to make and were the biggest thing in the whole country. And that's what he talks about, is how does something that dumb and that simple tip to the point I mean, we have the simplest thing to fix this system sitting right here. Like we're talking about it, we're looking at it, we see it, and yet we can't figure out a way yet to really build it in a way that you just it's like an uncontrollable beast that you just can't stop it. And a lot of it is we don't have the money, we don't have the clout that, the big insurers and the big hospital systems do when they build their, $18 million extensions with, nonprofit status and all that kind of stuff. But I tell people the only way you slay the beast is you stop feeding it. It's a David versus Goliath. And I know that in my lifetime I probably won't see it the way that I really wish it would be, but I'm certainly not going to stop trying to leave some seeds around to make it better, because the reality is this our kids and grandkids future depends on this. um I mean, they're going to go broke from this. It's just not sustainable. They're all going to be employed. They're not going to start their own businesses because they won't be able to afford to do it. So I think that's how we do it. It's the hard answer, but I think the real answer is you just literally plant seeds across the country in areas that you can, and you just try to build that army and let it grow as best as you can. But that's where, my call to action is, I say to, Doug mentioned other docs, just not willing. I was on that side of the coin. Especially in primary care, you're risk averse. You got a mortgage, you got student loans, you got kids. You're not going to leave an employed position and take the risk, like I did and like some of my colleagues did. So we've got to build a way that it's sustainable, for them to say, hey, you know what? We got 300 lives to start, that can at least, take care of my overhead or whatever,
Lights
and
on.
help people grow.
Mm. It's a paradigm shift you're talking about.
Yep.
Mm.
Yep. You got to change the way that people think. And that is a really, really, really hard thing to do. You almost have to, unplug them from the matrix and plug them into a different, you know,
Well, and they don't
portal.
even understand the matrix they're in. There's a
Right.
learning curve there, and they don't even understand the model that they're in right now. So now we're asking them to learn a different model. But you
That's
were
what I say. I say the reason direct primary care and direct contracting and all that stuff that is so confusing to people is because it's simple.
so
Yep.
people are like, "Where's the catch?" Yeah,
Yep.
where's
Yep.
They're
the
so u- they're so used to the convolutedness of the construct that we have and the complexity of, the insurance side of things, navigating the system side of things. Why is it so hard, to get my primary care doc to take care of this issue that seems so simple to me without referring me, all over the place, or me having to come back for 4 different visits and pay a deductible every time? It's because the system has put a 7 cents on the dollar value on primary care, and you get what you pay for. If you want to put a mansion on top of a foundation that's, ridden with termites, then let's build the healthcare system that we have again. If you want to fix it and rebuild the foundation so that you can then have all the bells and whistles and all the good stuff, in an accessible, affordable way, then let's man up and grab a hard hat and start working. But that's it's a lot of inertia, and it's a lot of like Mark has a great quote. He always says, people do want to change. They just hate the process to change. And it's true. If I'm dealing with somebody who's morbidly obese, they didn't get there overnight, and there's many factors that go into why they're obese. So I'm not going to be able to sit there and say, hey, in a month, even if I send you for gastric bypass surgery, that's just changing your starter. It's not changing the fuel. It's not changing the carburetor. It's not changing the muffler. Like, that's on them to do, and it's not going to happen overnight. So,
Yep.
that's what we're up against is people want to change. I think deep down people know this system sucks. I mean, especially the people who are in it. Whether you're a physical
Yeah.
therapist, a nurse, a physician, a psychologist, people know the system sucks. But are you willing to bear the pain to detox from it? Why do addicts keep using? Because they don't want the pain of the detox.
Right. It's scary. Yep. You were going to say something, Doug, and I'm sure it was brilliant when you were on mute.
No, as I listen to this, right? I mean, it's I don't disagree. I think where Jeff says there's got to be a movement to some degree. I don't know. I think about it almost more in a scientific terms, the amoeba effect. 1 is 2 is 4 is 8, and so on. But I would agree similarly if you can find pockets within the country where you can begin that process, then all of a sudden they start to overlap one another in certain areas. And I think that that's a recognition that you're beginning to push out traditional thought, traditional norms, and in essence, you're beginning a movement. And my belief is that it's constantly growing, but we're in such an early stage of it, whether it's DPC, direct to employer, direct contracting, whatever that is. These are such new things for these employers. And yet at the same time, people are becoming more and more willing to rip the Band-Aid off and say, let's go through this process of change because we need to heal. Because that recognition is, to your point, right? Our kids can't afford this. Certainly our grandkids can't. So I think most business leaders are getting to that spot where they're willing to engage in that process. What I think is that we've got to really break this idea of buying from insurance and begin to truly get people to understand the provider is the solution. And we've used, whether it's network or insurance or whatever it is, as this vehicle that we think is the only way for us to access and kind of see our providers. And Jeff proves it. You don't need that. You can literally just put yourself out there and say, it's $100 a month and I'm here. Let's go, right? Let's sign the paperwork and this is it. Now we just engage in healthcare. And as more and more people realize that, this is going to take off. I really do think that it's going to result in a better experience.
I do too. That's what I hear from patients who engage in a DPC model. They're very happy and they're not going to go back.
They'll never go back.
Yeah.
Yeah, they won't go back because at that point, you're taking their provider away. You're taking their freedom, their choice away. And how do you think the provider is going to feel? All of a sudden that person shows up and they don't show up with a payment, but now it's a Blue Cross card. And all of a sudden the provider's like, oh no, not this again, right? And probably in Jeff's case, he's like, I don't operate that way any longer. I can't effectively take care of you.
I know other docs besides Jeff who don't, and they don't have it. So this brings up, we're going to have to do this again, right?
Of course.
And the next time I want to talk about, how does this model, what's in it for the doctor? We know what's in it for the member, what's in it for the employers and the community. I think the DPC model has an immense value for really nourishing a whole community. And that we could talk on that probably for another hour, I think.
Absolutely.
Yeah, I love that point that you just brought up about that though, because I've been saying that for a while, compared to, the title with Marcus Welby. I mean, it's kind of the medicine that we grew up with. And the reality is you look at the macrocosm of how we're paying for healthcare, and the fact that we're using the same stupid coding and billing system to pay for wart removal in the same way we're paying for quadruple bypass surgery. It makes absolutely no sense.
Yep.
Right. It makes
exactly.
no sense. But then you look at it from the microcosm of where does healthcare really start? And it starts in the community. And that's why, I trained in a community hospital. I did not want to do a family medicine residency at a big teaching hospital because truthfully, it's not where it belongs. It doesn't belong there. Specialties belong there. Like research belongs there. That's what we've done is we've gotten rid of primary care and that community hospital and even the specialist groups now, especially in my area, they all used to be independent. They're all bought up now. I mean, they're all hospital
part of the
employees
conglomerate.
and and to some degree, like, us, doctors aren't off the hook either. I mean, we're a major part of the contributing, to this problem is that we went through training that doesn't teach you business. It doesn't teach you what it's like working for insurance versus working for, a private group versus going on your own versus working for a hospital system. And you're left
Well,
coming out like, oh,
let's tack on another 2
what do
years
I do?
education.
But I think that the reality is he or she who controls the purse strings is who has control. And when you give that purse string over to somebody else and you say, hey, I don't want to do it, I don't want to learn about it. I don't want to, I know I'm going to screw up at times, and I certainly have not done everything right. I've never been a small business owner before, and it's certainly given me a new appreciation for a small business owner of any ilk, no matter what they're in. But it's your baby, and the only one you have to answer to is you and your consumers. And if I'm not a good fit, or I mean, I've had, to argue against what Doug said, I've had plenty of people that have left and gone back to the system. And hey,
Mhm.
it sucks. It sucks. It burns. You ask, what could I have done different? Could I have done better? Is it just a product of, they need to go back and relapse again, whatever it is. But that's the beauty of a market, is if I'm not providing the value
Right.
to the people, they leave.
Well, and this brings up another, and I know we've been talking, we'll have to wrap up here, I'm sure, because I could talk to you guys all afternoon, but it begs the question of, is there a world where both of these two, ecosystems can coexist? I tend
Yep,
to think
I
there is.
believe they can. Well, they
100%.
have to. They have to. You can't not. I mean, people are going to get sick. You're going to get cancers. You're going to have heart attacks. So we have to have a way to deal with that. But I think
Right.
what Jeff's basically saying is, let's quit looking at that as the tip of the
Is the
spear
main-
and begin to realize that primary health is the tip of the spear. And if we'll actually invest in that, we'll save money in the other areas a lot.
Oh,
Right.
amen.